Today we are speaking on peptic ulcer. A drastic evaluation has taken up in the diagnosis and the management of peptic ulcers since few decades. Peptic ulcer started with the concept of acid secretion and all sort of things, which in our era we studied about it. But with the evolution of drugs, the scenario changed throughout the world, even in India. With the coming up of H2 receptor antagonist for the first time in India, there was a drastic response in the treatment of peptic ulcers, and gradually the scenario was that the number of cases was decreasing in our part of the world. Normally when we were interns, we had a case, routinely one or two cases of peptic ulcers or total ulcer to be operated in the routine OP. But gradually that number started decreasing with the evolution of H2 receptor antagonist. This was way back in 70s, 60s and 70s. After that, in 90s came back, the PPI came up. PPI in fact changed the whole scenario, the whole scene of peptic ulcer. In fact it disappeared, and nowadays you also see that the routine surgery for peptic ulcer is absolutely an obsolete thing. Not done nowadays, it's rarely done. Then came in yours setup H. pylori. H. pylori is one organism which is very notorious for its recurrence and very notorious for its harmfulness. H. pylori can be manifested in many of us, because of unhygienic habits, not washing your hands, not cooking your meals properly, staying in an overcrowded place, eating in an overcrowded place. These are all conditions that of infection of H. pylori. This can even happen to a child. So persistent infection of H. pylori gradually leads to peptic ulceration, gastritis, peptic ulceration, and even malignancies. So to diagnosis H. pylori, a few words about H. pylori I should tell you, is done through urea breath test, where you given a tablet of urea, and when you breathe out, urea is given out, and that is tested out. Urea breath test. It is measured by stool, and it is also diagnosed by endoscopically by rapid urease test or a flow test. These are the methods to diagnose H. pylori infection. So this is how the evolution of peptic ulcers came. Peptic ulcer normally is a duodenal ulcer, number one, most commonly seen. Gastric ulcer, less commonly seen. And anastomosis ulcer. Anastomosis ulcer is, suppose the patient has a gastric anastomosis, a gastrojejunostomy or gastroenterostomy in any part of the done earlier in his life or done for some other reasons. There in the enterostomy done site of anastomosis, you get an ulcer. So as far as to start with duodenal ulcer, it is situated in the first part of duodenum. There are certain dictums you should have to know about it. It is situated in the first part of duodenum. It is said that the duodenal ulcer, the anterior part of it bleeds, and the posterior duodenal ulcer, anterior perforates, I have to correct, anterior perforates and posterior bleeds. So normally a perforation, when you get a case of perforation, which is very common nowadays also, it is anterior ulcer which perforates, anterior duodenal ulcer, and the posterior one bleeds. Now how that posterior ulcer bleeds? Normally the ulcer is based over a gastroduodenal artery, which I was talking about in our last class. This gastroduodenal artery is eroded and a massive hematolysis occurs, and melena of course. So this is the dictum with peptic duodenal ulcer. The anterior perforates and the posterior bleeds. As far as gastric ulcer is concerned, it is situated in the lesser curve of the stomach, especially at the angle of angularis incisura, where you diagnose it, and the dictum for gastric ulcer is that as for when it is diagnosed, it is considered to be malignant until and unless proved otherwise. So what the clinician should do? We go for endoscopy. We take multiple 10 targeted, at least 10 targeted biopsies from different side of ulcers, from the center, from the periphery, from the lateral aspect, everywhere, wherever it is portable, at least 10 targets of biopsies are taken and histopathology examination done, and normally you find that most of the gastric ulcers are malignant. So in cases of gastric ulcer, what you have to listen and remember is it is until and diagnosed, it is considered to be malignant. The anastomosis ulcer, it is a gastrojejunostomy, suppose it is done. It is the ulcer. Here the important part, an MCQ can come. The ulcer is situated on the jejunal side. It is never situated in the stomach side. And where there is an anastomosis done, it is situated in the jejunal side. These are the three important things for your questions in examinations. Now, how does the peptic ulcer or the gastric or duodenal ulcer present? The most common symptom is pain. Pain is usually in the epigastrium. It's a gnawing type of pain, and it varies with intensity and it wanes off itself. Periodicity. Periodicity, you have to understand it, this is very important. Periodicity means the patient has this trouble, suddenly finds himself after a couple of days that he is relieved of all his symptoms, and finally for 15, 20 days or even months, and thereafter again symptoms recur. So this periodicity is there in cases of peptic ulcer. If presentation is a gastric ulcer or a duodenal ulcer or the infection due to H. pylori, there is a loss of appetite and there is a loss of weight. There is burping, there is bloating, there is flatulence, there is dyspepsia. These are the upper GI symptoms associated with the peptic ulcer. When you come over to the complications, you can have vomiting, you can have bleeding. These are and the patient may present with you straight away with bleeding or vomiting. So these are the clinical presentation of peptic ulcer. Now how do we diagnose it? The mainstay of diagnosis is endoscopy. We do an endoscopy, you find the ulcer in the lesser curvature of the stomach, go for a biopsy for at least 10 targets, and wait for the histopathology report, and thereafter manage accordingly if this is malignant. If you get an ulcer in the first part of duodenum by endoscopy, you diagnose it, treat it. Nowadays we have so many good drugs that treating the ulcer medically cures it. The diagnosis is done with endoscopy, and suppose we don't get any ulcers and the patient has symptoms of peptic ulceration, then in that case what do? We take a brush cytology through endoscope. We put in a brush inside, as I told you, through the working channel, and we take a cytological layer from the antrum, and that cytological examination is done for H. pylori. A rapid urease test is done, and then we find out whether the patient is positive for H. pylori or not. If it is H. pylori positive, then we treat accordingly and the symptoms wanes out. This is how we present the patient presents you, and this is how we diagnose it. Now the management. Nowadays essentially the management of peptic ulceration, be it due to H. pylori or any other cause, is medical treatment. Basically, what do we start with? Now we start with, in the case of 70s, we had PPI, we had H2 receptor antagonist. that is ranitidine, famotidine and other drugs, and that gives a partial response, a very good response in those days. Nowadays also you get a good response, but we have a better choice of PPI, the omeprazole, the pantoprazole, the rabiprazole, the esomeprazole, and now that they are doing very well and completely the ulcer is healed with these drugs, the long-term treatment. But if we have H. pylori as associated infection due to ulceration, leading to ulceration, then in that case we start a triple drug regime, a quadruple drug to be. First is an antibiotic, that is we use clarithromycin or amoxicillin. Clarithromycin or amoxicillin. This is the antibiotic we use. We use metronidazole. And then bismuth. Bismuth is a compound to be added there in eradication of PPI, and finally a PPI. These four combinations: antibiotic, metronidazole, bismuth, and PPI. These four combinations for 2 to 3 weeks eradicates H. pylori as such. This is the medical treatment. Now, a few words we should know about the surgery, what exactly we used to do early. In early stages, in early days, in our days when we were interns, there was a routine surgery for ulceration in every routine. What do? We had one operation which we started with, that was Billroth 2. Billroth 2. What is Billroth 2? Billroth 2 is a partial gastrectomy with gastrojejunostomy. This is Billroth 2. Partial gastrectomy with gastrojejunostomy. This is what it started. But what we found in our days, that after this operation a lot of complications resulted in the patient. The patient was not very happy. They had very much distension and other problems. Then we started with truncal vagotomy with drainage. Truncal vagotomy with drainage. Now what does that mean? Truncal vagotomy is that we cut the vagus. The best way to cut it is the lower end of the esophagus. We feed it and we used to cut it and do a drainage. Drainage means a bypass. A bypass to stop the stasis as the vagus is cut. Results in gastric stasis, which is to avoid that drainage operation was done. That is a gastrojejunostomy or a pyeloplasty. This is the second operation which was done in those days. Then came an era where nothing was done of these things, no drainage, nothing. Then we went over for highly selective vagotomy. Highly selective vagotomy. Highly selective vagotomy. What is the mean? Here we dissect out, we cut out all the fibers supplying the parietal cells, and we leave nerve. Remember this, nerve of Letarjet. Nerve of Letarjet behind, it supplies the antrum. Now this operation was highly appreciated and highly successful. This resulted in no stasis and it had best results. But when it was seen that the disease itself is vanishing out with the involvement of these drugs, coming up of these drugs, this operation also becomes obsolete. So all these operations became obsolete nowadays. You can't see this in our OTs. Now we come across operations of peptic ulcers only when it's complication, with its complication, which we will be dealing in next classes. Now this is all for peptic ulcer as such. Now what complications do we have in peptic ulcers? Peptic ulcer, the complication what normally we have in peptic ulcer is a hemorrhage that results in hematomesis and melena, perforation, that is the normal thing, which comes up in our emergency with peritonitis, perforation, duodenal ulcer perforation, that is the anterior ulcer which perforates, and finally the stenosis that results in pyloric stenosis. These are the three major complications what we get nowadays. But the maximum amount of patient coming nowadays with peptic ulceration complication is with either hematomesis or with perforation. But mind it, these patients are only those patients who are not conscious, who are not having a healthy habit of living, and they are living in the crowded places with these, they come with this problem. Unhealthy eating habits, smoking, alcohol, all these results in this sort of complications. So finally, this is all for peptic ulcer for today. We will deal with the complications of peptic ulcer tomorrow. Thank you. हो गया? हो गया? हो गया? हो गया? चले हो गया उससे बात कर रहे तुम लोग अपने अपलोड करेगा बुला नहीं उसको वो बंदर बढ़िया से बोलते हैं किसी को तो पाल टिकट है जितना मत बोल रहे हो देख लेगा सब ठीक है तो ये तो कुछ बोल रहा हूँ नहीं है कौन नहीं उठा रहा है
कुछ आइए मेरे लिए प्लेन है
हाँ चल रहा है
समय भाई बोलो
तो रिकॉर्डिंग तो चालू है
किसी से बता रहा है
यहाँ बंद कर दिया
रिकॉर्डिंग चालू है
हाँ चेक कर लीजिए चेक कर लीजिए एक बार